Good evening, Dr. Bajaj. Thank you so much for taking out time from your busy schedule and being with us on this important series of trends and outlook on the healthcare industry. So, you would love to hear more from you about your background and experience. You founded Ujala Cygnus and scaled it up to 28 hospitals now into your 2 and Tier 3 cities. So maybe before we start the Q&A, Dr. Bajaj, love to hear from you. Where did you start? How did it all start? And where you brought it today before we move forward.
Thank you very much, Vishal, for having me here. Thank you so much. Lovely office you have. I started long back. Actually, I was studying to be a gastroenterologist after finishing my MD in internal medicine. And I come from a resource-constrained background, to put it politely. So my father and mother both came into India as refugees into the country. My father used to live in a horse stable, 10 feet by 6 feet area, with almost 14 other people in the stable.
Wow.
And in his early days, he used to make kites for a living. And he decided very early on that the way out of poverty would be to literally climb out of poverty. And, he said, I will climb out of poverty by education. So
Right.
I will study and make my family study. But of course, he could not study in that horse stable because it was full of people and they were working all day. And at night, if he tried to light a lamp, they would all beat him up saying that now let us sleep, And the more important worry for them was if the kites catch fire, we won't have anything to eat tomorrow. So he literally had to climb out. He brought a rope from somewhere and put it and climbed onto the roof of the horse stable with that rope and, studied there, stayed there for a very long time.
Right.
So then he made us all study at the peril of death. And his favorite dialogue was, if you want a roof on your head instead of under your feet like I had, you have to study. And that is how, luckily I got into a medical college, and government medical colleges are very, very cheap. My annual fees was 400 rupees something.
Right.
So after finishing my MBBS, I went for MD. And then after finishing my MD in internal medicine, I came back to Delhi to do gastroenterology.
Okay.
And now since I was back, the family looked up to me to provide help. So anytime somebody had a problem, they would call me. That somebody's had a heart attack, somebody's had a head injury, somebody's critical. We are bringing them to Delhi, get a bed, arrange something. But sometimes they wouldn't turn up. I would keep waiting for them. And then I would find out later that, the patient died on the way. So we are back in the village now. And one particular conversation really blew my mind that, one day I went to such a funeral and they were talking, said, maybe it's good he died on the way. The last one that did manage to reach Delhi from our village spent 15 days in the hospital, had to sell his house, had to sell his fields. And then he died, and now look, his widow is begging on the streets. So at least this family has something to live by. It was really an eye-opener that for this community, financial outcome was more important than physical outcome.
Yeah.
Because generally, if you talk to us, we would do anything to save a patient, right? Or kuch bhi karenge, doctor sahab, bacha lijiye. But for them, it was a big thing that the entire family had slipped.
Yes.
So I just thought that, there are already 20,000 doctors in Delhi. What will one more achieve? So I dropped out of gastroenterology to start this small town hospital chain that, provides high quality healthcare in small towns at their doorsteps, so they don't have to travel, but at very affordable prices also. So this is how it started. Luckily, we got very good co-founders, very good doctors to work with us.
This was in which year?
So that was way back 16, 17 years ago.
Right.
So, yeah. And then we kept getting good investors. We still have very good investors on board who realize the importance of the mission of this, who work with us to provide high quality healthcare at affordable prices.
Yeah.
So this is how it has gone. Now we have 28 hospitals across 6 states of North India we have served more than 3 million patients till today.
So also congratulations for yesterday. He has been restored with the Healthcare Entrepreneur of the Year award.
Thank you, sir.
So tell us a bit more about this whole setting up these hospitals. What were the drivers? So you spoke about what made you start it, right? So from there to today, 28 hospitals, it must not have been very easy journey, right? So what's been driving growth across North India, and what have been couple of key learnings over the course?
Yeah, so see, historically, the district headquarter for any district has been the center of attraction for the community to do anything. So if they want to sell their produce, they'll come there. If they want to buy anything, do shopping, they'll come there. Access banks, they'll come there. Access the government, they'll come there. Similarly, it was the situation till I think the 1980s for healthcare also. For every healthcare need, they used to come to the district headquarter. Then in the 80s, healthcare suddenly transformed into a very super specialist, machine heavy kind of an industry from a simple doctor patient relationship industry. So you needed cath labs with cardiologists to manage heart attacks. You needed neurosurgeons and CT scans to manage head injuries. You needed ICUs, ventilators, dialysis facilities to manage complex trauma, etc. And then these district headquarters could not really keep pace. First, because of human resources, we still, I think all over India, we produce less than 800 cardiologists every year for 1.5 billion people. We produce less than 100 endocrinologists every year for 1.5 billion people and 100 million diabetics. So at that time, human resources were even more scarce. And then machines were very expensive. So the district headquarters could not keep up pace. And all the tertiary healthcare then shifted to the big capital cities, Delhi, Bombay, Chandigarh. And then the district headquarters just fell apart. What we are trying to do is give district headquarters that same prominence that they had 50 years ago, where they were the center for each and every need of the community. And it is very easily accessible. It's a natural flow for them. They have to go there anyways. And they reach their headquarters within say half an hour, 40 minutes from anywhere in the district. So that is what our aim is. India has more than 810 districts for 1.5 billion people. So almost 2 million to each district on an average. And each district needs a good quality hospital. 2 million people, at least one good quality tertiary care facility with all emergency facilities, a facility to manage any disease, especially where the golden hour is of great importance, where you actually run the risk of losing your life if you do not access healthcare within the first hour, like a heart attack. So all these districts should have that kind of facility. Unfortunately, in India right now, majority of district headquarters do not have, only a minority have these facilities. So that is what we are trying to do, and this is the mission that we are following.
Wow. So you obviously want to continue expanding into other states also, or region maybe. You currently focus on North, right?
So right now what we have seen is that North India and East India are usually at the bottom of all healthcare indices that you come across, right? Almost all the aspirational health districts are in these regions. West and South India are much better supplied and much more aware compared to North and East. So we understand North a lot because I belong to North India, studied here, all my family is here. So we really understand North India deeply, and the need is there. For example, one of the states we work in is Uttar Pradesh. Uttar Pradesh has a population of almost 22 crore people, I think. Correct. 220 million people.
Correct.
It's almost like the European Union, right? And so see how much, and if you combine Uttar Pradesh and Uttarakhand, which were till recently one state, and we have presence in both, population almost reaches near to US population. So if you compare the healthcare facilities in US compared to these two states, there is still a lot of need. So it is really underpenetrated, right? So we have a lot of potential there. A lot of work to be done in North. So once we do that, then we can think of other regions as well.
And the expansion that you've achieved so far has just largely been, I know you've made few acquisitions also. So is it largely based on acquiring existing players, or is it organic?
So this model came about again because of scarcity. So I had no money to, as I said, build a resource-constrained family. So I had no money to build a hospital or buy land, but I was clear I needed to do something, right?
Correct.
And as I said, the district headquarters had fallen out of favor with the community for providing good quality healthcare.
Right.
So there are many hospitals in these district headquarters, the building is there, but they have not been able to keep up and not been able to equip it properly, either with machinery or human resources.
Yeah.
And they are struggling and not doing well. So this is how we got the first hospital, that those owners used to come to me to Delhi to consult for their medical issues. So I was their doctor. And they said, oh, I said, we need to do something. I said, we have a hospital there. Why don't you come and see it? I said, so if you have your own hospital, why do you come to Delhi to consult? They said, there are no doctors there. No, we are unable to get good quality doctors. So each district has like these 2 or 3 hospitals which are really struggling to keep up. But it's not necessary for us to acquire running hospitals only. So our aim is to identify a town where we want to be. And once we've identified that town, any building that suits us, it may be a hotel. We've converted 2-3 hotels. They are converted very easily into hospitals. A restaurant can become your emergency. The banquet hall can become your ICU. The rooms are already very good quality. We can convert malls also. We've converted 1 mall. So a building in an identified town is what we look at. If it is already a running hospital, that's a bonus for us. But we don't invest in land, real estate, or building up the building, because we feel that we are not real estate players. Our money is much better utilized if we put it in equipment, doctors, etc.
And if you go a step back, as you rightly said, you select a particular city for either acquiring an hospital or setting up an hospital. If you go a step back, before selecting a city, what are the key criteria? Probably you would look at the top 3 criteria. Okay, this is the right city I should get in.
Yeah, we can really simplify those criteria. People will feel it must be a huge exercise. You can actually simplify it. The city should be close to our existing operations, because we work in cluster models. It allows us to share a lot of bandwidth in terms of management, human resources, machines. So should be close to where we already are. It also addresses the need for people going to a hospital quickly in the golden hour, because if you're too far away, then the journey becomes too long. Second, it should not have a very big facility already, which is already addressing the community's needs. So if we are needed, we go there. Third, it should have a very good school, because doctors became what they became because of studying. So they want their children also to study well. If we don't have good schools, then it is difficult to attract and retain good quality doctors, because then they have nowhere to send their children to. They need to go out in the evenings, have some fun. So if there is absolutely nothing,
create that ecosystem.
If the minimum level of urbanization is not there, it is difficult for us to retain good quality doctors in those towns. So we've learned it the hard way. So we've opened hospitals in towns which had none of these. So it was very difficult to retain good quality doctors. They would keep leaving. We've also opened earlier in towns which had already got a very big hospital already. So we were not really needed there. So we've learned it the hard way.
Journey.
So we've had to close down hospitals to learn what really we need to do.
Given that you scaled up so fast and in this short span, what has been your experience from a post-acquisition standpoint? Let's say if you acquired a hospital, obviously that comes with a different set of dynamics, different set of doctors, different management. End of the day, you need to have a seamless ecosystem through all your hospitals, so that the patient care, the core service is scattered. So how has been your journey from a post-acquisition standpoint?
So I think if you give a good culture to the doctors working there, if you assure them that there are no revenue targets, or if you actually disincentivize them for unnecessary interventions, they're actually happier. They feel that now we can focus on good quality work. That is all that is needed, and rest of the things, the management is there. And as a doctor, I really understand what their pain points are, what their pleasure points are, what they like to do, what they don't like to do. So it becomes easier to integrate. Of course, you do need to weed out some bad actors, because in every industry there will be some bad actors. So you need to identify them, you need to weed them out, you need to keep pointing out to them that we know what is happening. So this is not allowed in our organization. Then you need to drive a lot of efficiencies, because we work at very low costs. So that we need to work into the culture slowly and surely. And then, of course, the biggest ethos that we have, that we treat each and every patient who walks into the door. That ethos has to be really from the top down. We have to reinforce it again and again to each and every person working in the organization.
Got it. And has tech played a part in getting those efficiencies?
A lot. So we won't be anywhere without technology. So we work on an integrated HMIS, which is a cloud-based HMIS, which is uniform across all our hospitals, and which we can see sitting at the corporate level. And then we do a lot of data analytics. We have a lot of top-up softwares on that to analyze exactly what is going wrong, what is going right, where we are making these errors. We have a lot of customer facing technology also, like you can easily book any facility on a WhatsApp chatbot. So we have a very intelligent chatbot on the WhatsApp which can communicate. You can get your reports, get OPD appointments, etc. We have a lot of tech enabled ECG machines that we install in outreach clinics near our hospitals. So all these things, we have a lot of AI-enabled radiological reporting to do, urgent reporting in the night where we don't have on-ground radiologist available at that time. So all of these technologies, we employ a lot of it. Yeah.
It's actually phenomenal. I think the scale and, especially given you're operating out of tier 2, tier 3 cities, having these initiatives to build tech is phenomenal.
Thank you.
So congratulations for that. So since you're operating in tier 2, tier 3 cities, how does Ayushman Bharat or some of the government schemes, so what percentage of your business is dependent on them? And two, if it is significantly dependent on such schemes, how do you manage the working capital and other operational sort of challenges?
So almost 60% of our revenues are still either out of pocket or private insurance, where we have practically a negative working capital because private insurance pays within 30 to 45 days.
Yeah.
And we usually pay our vendors, etc., in 45 to 60 days. So that works well. But 40% of our business is dependent on Ayushman Bharat, government schemes like ESI, CHS, CGHS.
Yeah.
So there, of course, the working capital pressure is there, like for everyone else that works with the government. But the good thing is that the patients who have these Ayushman cards, in the early days when we had started, before Ayushman came in, had actually no money to pay. So we were practically treating them free of cost in our early days. Now at least they have Ayushman cards, so they pay something. It may be a very low price and it may take longer for us to realize, but there is money on the table. What we've realized is that accurate billing the first time is very important to make sure that your claims are processed on time. If you make even one error and that claim gets stuck in an error and goes back into the cycle, then it becomes a very long cycle for us to manage. So that is one of the key things to focus on. Bill accurately and bill it accurately the first time. Don't make even one error. If you do that, then you may still manage, but again, it is a tough thing for any organization to manage 40% of revenue stuck in working capital. That we have been advocating with the government for a very long time, and I hope there will be some action on it sooner than later.
You would also have got higher volumes because of Ayushman Bharat, so the footfalls would have gone up, right?
Yes, of course.
So your cost of acquiring, I don't think we should call it cost of acquisition, but at least your number of patients, obviously, because of increased awareness and affordability, that would go up.
Yeah, I think you really hit the nail on the head, because we keep talking about, in India, the talk about healthcare is always based on scarcity. This whole story of scarcity. Oh, we don't have enough doctors. Oh, we don't have enough beds. We don't have enough hospitals. But even then, why do even the top hospitals run at 65-70% occupancy rates?
Correct.
Right? That is the numbers you see everywhere.
Correct.
It's only the government hospitals that are overflowing, and that too only the good government hospitals attached to medical colleges. Otherwise, even they are empty.
Yeah.
It is because of the A's that you pointed out. There is no awareness, there is no availability, there is no affordability, there is no access. So you need to cross out all those A's from the patient's journey to make sure they flow into the
Correct.
hospital. Because if you see the numbers, it is not just that we are underserved, we are under accessed also.
Correct.
India has one of the lowest hospitalization rates in the world. It's not because we are the healthiest people. It is because of all these A's.
Correct.
The Lancet Commission for Surgery in a paper said that in a LMIC country like India, you should have about 5,000 surgeries per 100,000 population per year.
Yeah.
That is the average. And this number can go as high as 23,000 per 100,000 in countries where awareness is extremely high and out of pocket is very low, like Scandinavian countries.
Yeah.
Even Brazil, the number is around 13,000.
Wow.
But now you see how many surgeries were done in India last year. Only about 2.2 crore surgeries. So our number for 1.5 billion people is only about 1,500, right? So where are the rest of the 3,500 people that Lancet assumes should have had a surgery? They are not coming into hospital, right? That is why we have the largest number of preventable blind people in the world. People don't even know that a cataract surgery can, make you see in 5 minutes. That is why we have all the world records coming out of India, where this proud doctor is standing next to this girl with a 20-kilo tumor. That we removed this 20-kilo tumor. Everybody is posing. That tumor should have been removed 10 years ago when it was like 200 grams, right? This poor girl has been carrying it like a baby, and nobody knows. So we do a lot of village outreach programs that we call the Sehat Chopals. So we go village to village creating awareness around all our hospitals. So we do almost 25-30 chopals every day. And in those chopals, we frequently see such patients. There is this old woman lying on the cot and they're like, oh, she's too old, so she can't see, she can't walk. She has this huge lump in the body. And we have to make them aware that she can't walk because you get a knee replacement done, she'll start walking. You get a cataract surgery done, she'll start seeing. You remove this tumor, it's not very difficult to do. She'll start feeling better, lighter. So all this awareness has to be given. So this is where this insurance and awareness and affordability plays a huge role in getting more patients into the hospital than was happening earlier.
So while you said you've been focusing on tier 2, tier 3 cities. So how do you see the next 5 to 6 years the healthcare initiatives evolving in these cities, and more importantly from private equity standpoint? How do you see that outlook or thought process on those hospitals which are evolving in these cities?
So I think we are at a very sweet spot in terms of both demand and supply. Demand because, as I said, because of increasing awareness, digital penetration, and insurance penetration, people are getting more aware. And all this latency of surgeries and admissions that is not happening will start to happen. With the government focus on insurance and their low prices, the big city hospitals cannot afford to work at those prices. So those patients, if they go to big city hospitals, will either have to spend out of pocket,
Correct,
or they will have to come to hospitals like ours. So this huge demand is coming in, it will come in. We are really at the right spot. In terms of supply also, how we started out this story of scarcity, not enough doctors. But if you see in the last 6-7 years only, the number of MBBS seats has doubled in the country. And now these young students will now start coming out. And once they do their MDs, the MD seats are also increasing. DNB seats are getting added. So once this wave of doctors in the next 2-3 years comes out, they will have to find some employment and they can't all go to big cities. So we are right at the right point to get these doctors working with us. So in terms of both supply and demand, there is going to be a huge uptick in all these small town hospitals, and I think that is where the real growth will happen.
So, in terms of how, as a country, you think it's how important it is to maintain a balance between the quality care and growth, right? So, because Somewhere I was reading today also that most of the hospitals, irrespective of the size, are now private equity backed or they've got private capital, right? So obviously there is a growth expectation for both the investors and the business also. And on the other hand, we talking about people talking about excellence in terms of the clinical excellence. So how do we balance the two, and how critical it is to make sure it is sustainable growth? Because growth to hai, everyone is saying that next 10 years, I think it's phenomenal growth that is there for healthcare.
So clinical excellence is the bedrock of any healthcare facility.
Yeah.
So you cannot say that if you are building for the poor, you can build poorly.
Yeah.
And we walk the talk on a daily basis. So it's not like I expect that if we have a hospital, I will go to a big city hospital and the community will access my hospital, right? We cannot do that. So my daughter was born in one of our hospitals only. My son has had 2 surgeries in one of our hospitals. So we walk the talk. One of our partners had a massive MI in one of our hospitals. He was revived, done a cardioversion, he was clinically almost dead for a while, but we managed to save him, one of our own partners at that time. So clinical excellence is something that you have to keep at the core of all your offerings. Now comes the second question on affordability. So affordability and quality of service, I think anyone in the country who has had the misfortune to access healthcare services outside of India will never ever blame Indian healthcare for either quality or price. One of my friends recently, so we've all heard of horror stories in Europe and US.
Correct.
In US, if you call an ambulance, even if you're fully insured, I think the copay will be around $2,000 just to call an ambulance. So like 1.5 lakh rupees just to call an ambulance. Treatment is separate. One of my friends recently went to an Asian country, Bali, and he fell sick. He thought, I am in Asia, healthcare will be like India. So he called a doctor, and the doctor came in and said, nothing, you have just gastritis, gave him 2 tablets. The charge was 8,500 rupees for 1 doctor consultation and 2 tablets. You can walk into any clinic, the topmost doctor will not charge you more than 2,000 rupees, I think, right? So healthcare affordability is very relative. Compared to the rest of the world, we are already extremely affordable. I think even if we go slightly higher, we will still be more affordable. It is for us to make sure that we refrain from profiteering. Profits and profiteering are 2 very different things. Profits are necessary to sustain any enterprise. You cannot live without profits. Otherwise, you will close down and then you cannot serve any community.
Yeah.
So that is very necessary for you to, as I said, around 500 districts need these facilities. So if you have no profits, then you cannot go to more districts. But of course, profiteering is not something that healthcare or education should strive for. Impact and purpose and quality has to be supreme. If you offer that to the community will make sure you earn good money. There won't be any problem.
Excellent thoughts. So thank you, Dr. Bajaj, for taking out time. I think in the interest of time, we'll probably close it here. We'd love to continue talking to you on different forums. So thank you again.
Thank you, sir.
Thank you, Dr. Bajaj.
Thank you.